Good morning, dear colleagues. I would like to sincerely thank for the invitation. And the topic of the presentation is neglected anatomical areas in ovarian cancer, significance for optimal debulking surgery. Recently, we have published an article for the same topic in the journal Cancers, and we also published an article about surgical anatomy of the livers. The majority of figures from the presentation are from these two articles. Ovarian cancer, the most lethal gynecological malignancy, usually presents in an advanced stage, characterized mainly by peritoneal and lymphatic dissemination. Ovarian cancer necessitates a complex surgical approach, usually involving the upper abdomen with the aim of achieving optimal site reduction without visible macroscopic disease R0. Failures in optimal site reduction, essential for prognosis, often stem from overlooking anatomical neglected sites that harbor residual disease. The following 8 neglected anatomical areas will be described in the presentation. The first and the biggest one is the omental bursa. The omental bursa, also referred to as the lesser peritoneal sac, is a natural space situated between the stomach and the pancreas. The omental bursa can also be divided into an infragastric and a supragastric part. The infragastric part is located posterior to the greater omentum, caudally, and posterior to the stomach. Surgeons may encounter this part of the omental bursa during omentectomy. The supragastric parts, which is shown in this figure, is located posterior to the lesser sac and cranial to the pancreas. The following anatomical structures could be encountered in the omental bursa: the hepatoduodenal ligaments and the foramen of Winslow. The foramen is the only natural connection between the omental bursa and the greater sac. The arterial vessels which could be found in the omental bursa is the celiac trunk, also referred to as the celiac axis, and it is the first anterior branch of the abdominal aorta. It arises immediately after the aortic hiatus at the level of T12L1 vertebral body. Here's the celiac trunk. The celiac trunk runs horizontally and above the splenic vein before trifurcating into the left gastric artery, splenic artery, and common hepatic artery. The common hepatic artery later divides into the gastroduodenal artery, the proper hepatic artery, and the right gastric artery. The portal vein is the main vessel entering the liver, responsible for carrying about 75% of the blood flow. It arises from the confluence of the superior mesenteric vein and splenic vein. The drainage patterns of the inferior mesenteric vein have been identified, and they are variable. The most common is draining into the splenic vein, like in the figure. This is type A1. The superior mesenteric vein is type 1B, or the confluence of the superior mesenteric and splenic vein. The portal vein enters the hepatoduodenal ligament and divides into the left and right branches at the level of the porta hepatis. Lymph nodes in the omental bursa are many celiac lymph nodes, and they are situated near the origin of the celiac trunk. These nodes are terminal as they collect lymph from nodes located near the common hepatic, splenic, and the left gastric vessels. Celiac lymph nodes also drain lymph from most internal hunger organs into the cisterna cavai. The number of hepatic lymph nodes is variable. They can be divided into hepatic, superioric, and cystic nodes. The hepatic lymph nodes can be identified in both the porta hepatis and the hepatoduodenal ligament. The spread of ovarian cancer into the omental bursa occurs primarily by two routes: transcoelomic, also known as peritoneal spread, or progressive lymph node dissemination. In advanced peritoneal ovarian cancer, the omental bursa is often affected via the transcoelomic route. Peritoneal metastases in the lesser sac can be found in the following anatomical structures. You could see them. I will not point them separately, but mainly hepatoduodenal ligament, porta hepatis, medial aspect of the Wilson foramen, superioric space, fissura for ligamentum venosum. The peritoneal spread of ovarian cancer to the lesser sac is possible only through the foramen of Winslow. which is a connection between the lesser sac and the peritoneal cavity, and that was mentioned before. However, transcomomic lesser sac metastases are absent in cases of adhesions and occlusion of the epiboic foramen. For example, as a result of previous surgeries in the upper abdomen, with cholecystectomy being the most common cause of adhesions and obliteration of the foramen. Peritoneal spread to the omental bursa is linked with conditions such as cystitis, peritoneal carcinomatosis, high peritoneal cancer index, involvement of Morrison pouch, and diaphragmatic dissemination. However, tumor spread into the lesser sac does not consistently follow expected patterns. Supragastric lesser sac metastases are observed in 70% of patients with a normal suprachoric omentum. Interestingly, the lesser omentum can remain unaffected in about 1/5 of patients with lesser sac metastases. The percentage of lesser sac peritoneal carcinomatosis can be estimated in a few reports. However, the majority of studies combine description of both parametrial and lymph metastases. Some data reported lesser sac peritoneal metastases in 64% of patients with advanced ovarian cancer, and the celiac lymph node metastases were excluded from the study. Other authors reported that 67% of women with advanced ovarian cancer had omental bursa involvement, either peritoneal or lymphatic. The authors estimated peritoneal dissemination in the omental bursa in approximately 60% of patients, with approximately 80% heavy supragastric lesser sac involvement and approximately 20% heavy peritoneal dissemination and the hepatoduodenal ligament. The real incidence of cardiopharyngeal lymph nodes involvement is of celiac lymph nodes involvement is unclear, as systematic lymph node dissection is not routinely performed in this region. Studies have shown that patients with advanced ovarian cancer only benefit from removal of bulky nodes as part of optimal site reduction. Therefore, the majority of studies included the rate of metastasis among patients with suspicious celiac lymph nodes. Patients with metastatic celiac lymph nodes have higher PSA and more frequent portal-hepatic involvement, as well as more frequent dissemination of the mesenteric and parotid lymph nodes. Approximately 80% of patients, or more than 80% of patients with celiac lymph node dissemination had metastatic parotid lymph nodes. Metastases to the celiac lymph nodes are associated with extensive upper abdominal disease, hepatic metastasis, and a median of PCE of 21. Surgical approaches to the omental bursa are mainly four. The first one is dissection through the pars flaccida, which is shown in figure A. The second one is transmesocolic approach and the dissection of the gastrocolic ligament. Here is the omentum. This is the transverse column. C is a direct dissection over the greater omentum just below the curvature of the stomach. And D is dissection of the gastrosplenic ligament. In case of omental cake, dissection through B and C is harder to be achieved. Dissection of the gastrocolic and gastrohepatic ligaments provide good access to the omental bursa and celiac trunk, but it is insufficient for dissection of the hepatoduodenal ligament and portal hepatis. Theodor Kocher introduced a maneuver for the mobilization of the duodenum and head of the pancreas. This is a duodeno-pancreatic mobilization commonly used in visceral surgeries such as the Whipple procedure or in immersion surgeries for retroperitoneal hemorrhage. So the Kocher maneuver is also used for dissection of the hepatoduodenal ligament, portal hepatis, and suprarenal lymph nodes. The dissection plane is through the fascia of trace, which is seen here. The duodenum and the stomach are retracted medially. The incision line of the peritoneum is indicated by the interrupted black line. Here is the duodenum and the head of the pancreas. B is a dissection of the fusion fascia of trades. C is mobilization of the duodenum and the pancreatic head at the level of the left renal vein, which is seen here. The left renal vein is the lateral one mark of dissection. And on D, you could see anatomical structures after completion of the Kocher maneuver: the IVF, the portal vein, the duodenum and the head of the pancreas, portal hepatis, and right kidney. The cochlear maneuver is often combined with the catch-up brush maneuver, which represents a mobilization of the duodenum, mobilization of the standing colon from the retroperitoneum after dissection of taut fascia. The second anatomical neglected area is Morrison pouch. Morrison pouch, also referred to as the posterior right subhepatic space or hepatorenal pouch, and it is part of the right supramesochoric compartment. Boundaries: cranial is the posterior layer of the coronal ligament of the right liver wall. Caudal is the superior part of the right kidney. Lateral is the parietal peritoneum, where it merges with that of the peritoneum of the right diaphragm. Medial from lateral to medial is the hepatic flexure of the transverse colon, transverse mesocolon, the second part of the duodenum, and the porta hepatis. Anterior is the right lobe of the liver and the gallbladder. Morrison pouch usually is free of any fluid collection. However, fluid accumulation occurs in the pouch due to gravity. It is one of the posterior spaces of the peritoneal cavity. For these reasons, Morrison pouch is one of the most affected anatomical results in advanced epithelial ovarian cancer. The dissection begins with mobilization of the right liver wall, involving the division of the anterior leaf of the coronal ligament and the triangular ligaments of the right liver wall. The liver is retracted cranially, following the transection of the posterior leaf of the coronal ligament. The peritoneum is stripped from lateral to medial until the borders of the pouch are reached. Special attention must be paid to avoid a potential injury to the right adrenal gland, intrahepatic IVF, and right diaphragm. Additionally, it must be noted that there are small veins, infra and retrohepatic veins, draining directly into the IVF. On figure A and B in embalmed cadaver, you could see the peritoneum of the Morrison pouch. On figure C, you could see the tumor deposit, and a peritonectomy of the Morrison pouch is shown in figure D. The third anatomical negated area is base of the round ligament and the hepatic bridge. Base of the round ligament is often affected by tumor cells in cases of PCE more or equal to 10, ascites, peritoneal carcinomatosis at the Gleason capsule and carcinomatosis at the porta hepatis. There is risk of injury of the left portal vein. The hepatic bridge, also known as pons hepatis or pons hepatic, is an anatomical operation in which the liver parenchyma bridges between segments 3 and 4B of the liver. Consequently, a tunnel forms over the umbilical fissura at the base of the round ligament. Different pons hepatis have been described. The most famous classification is the sugar breaker classification, which established 4 types of hepatic bridge. So the first type, which is type 0, there is no hepatic bridge where the base of the round ligament is visible. Here, there is no hepatic bridge. On B is shown first type, less than 1/3 of the umbilical fissura is covered by the liver parenchyma. Type 2 is type 2 hepatic bridge. The hepatic bridge covers up to 2/3 of the fissura. And type 3, more than 2/3 is covered by the liver parenchyma. So there could be tumor cells behind the bridge, so it should be open. Risk of hepatic bridge metastasis involvement is higher in cases of peritoneal involvement of the round ligament and the PCI more or equal to 10. The left hepatic duct and the left hepatic artery are at risk of iatrogenic injury during resection of the hepatic bridge. 4 is film of the spleen. There are 3 types of metastatic patterns of splenic involvement in advanced epithelial ovarian cancer: Hewler, capsular, and parenchymal. Transcolonic involvement of the splenic humor is possible by 2 routes, via the omental bursa and the greater omentum. Ovarian tumor cells spread to the omental bursa and then reach the splenic humor through the posterior part of the gastrosplenic ligament. The splenic humor is also affected in the case of massive metastatic omental majus involvement, also known as omental cake. The majority of authors reported a rate equal to or more than 50% Hewler involvement in patients with advanced ovarian cancer, and Hewler metastases are more common than parenchyma 1. Women with splenic fever metastasis have a significantly shorter survival time compared to patients without fever disease. There is a risk of injury of the tail of the pancreas during removal of the spleen. In such cases, interdisciplinary discussion on postoperative management could be required due to the eventual pancreatic ductal leak or fistula. On the figure, you could see an example of fever metastasis in the spleen. Number 5 are suprarenal lymph nodes. The suprarenal lymph nodes wire cranial to the renal veins. They are divided into two groups. The first group is located on the left side of the aorta, inferior to the origin of the superior mesenteric artery, and medial to the left adrenal gland. The second group is located between the IVF and the abdominal aorta, below the inferior surface of the right liver wall and below the origin of the superior mesenteric artery. Most authors recommended the Cochlear maneuver or its modification to gain access to the suprarenal lymph nodes. There is also a left lateral approach to the suprarenal nodes modification of the Mattox maneuver. Surgeons should exercise caution when dissecting the adrenal glands, the suprarenal and renal vessels. It should be stressed that anatomical operations of the renal vessels are common. Also, the cistern KY and the lumbar lymphatic trunk could be damaged during dissection. The percentage of metastatic suprarenal lymph nodes rises to 36 in advanced epithelial ovarian cancer. The incidence of suprarenal lymph nodes involvement is associated probably always with metastasis to the infrarenal paraortic lymph nodes. Number 6 is retrocrural lymph nodes. Our team here in Varna do not have experience with these lymph nodes, so a discussion about these lymph nodes probably will be interesting. The retrocrural space is a triangular area bounded anterior and inferior by the two diaphragmatic crura. Here are the two diaphragmatic crura, and here's the retrocrural space, and posterior superior by the mediastinal pleura, and posterior by the thoracolumbar vertebra. The following anatomical structures are a part of the retrocrural space. Vessels such as aorta, azygos, and hemazygos veins, lymph nodes, fatty tissue, and neuron components such as sympathetic trunk, splanchnic nerves, and thoracic duct and cistern KY. Lymph nodes in this space are called retrocrural lymph nodes. These nodes communicate with the posterior, mediastinal, and paraortic lymph nodes. The progressive spread of lymph node metastasis in a cranial direction can reach the retrocrural lymph nodes. A diameter of these nodes greater than 6 mm can be considered suspicious in CT. Same data found that more than 40% of patients get metastasis to the retrocrural lymph nodes in patients with advanced epithelial ovarian cancer. Retrocrural lymph nodes have recently been discovered for ovarian cancer surgery. However, there remains a need and potential for greater awareness of this space, relevant to surgical dissection and lymph node assessment. Number 7 are cardiophrenic lymph nodes. Cardiophrenic lymph nodes are situated in the cardiophrenic region, which lies between the mediastinum, the base of the heart, the diaphragm, and the chest wall. There are mainly three groups of cardiophrenic lymph nodes. The anterior group, which is indicated in yellow, is bounded posterior by the pericardium and anterior by the xiphoid process. There is also a middle group indicated in green dots and posterior group indicated in red dots. However, ovarian cancer mainly affects the anterior group. On figure B, C, and D, you could see metastatic cardiophrenic lymph nodes on CT. Surgical access to the cardiophrenic lymph nodes can be achieved through transdiaphragmatic approach, which requires liver mobilization and diaphragmatic opening. It does not require the use of a chest tube, and the patient's position is not changed during surgery. The other approach is video-assisted thoracic surgery. And recently, Lucas Minnick described substernal approach. It is indicated when the diaphragm remains intact after diaphragmatic stripping to reduce postoperative complications related to entering the thoracic cavity. When dissecting the anterolateral cardiophrenic space, surgeons should exercise caution to avoid injury to the left phrenic nerve and the left pericardiophrenic artery and vein. Transcolomic and lymphatic dissemination in the right upper abdomen, ascites, extra-abdominal disease, increase the chance of cardiophrenic lymph node dissemination. Most studies showed a strong correlation between radiologically enlarged cardiophrenic lymph nodes and more advanced peritoneal carcinomatosis in the abdomen. Right upper abdomen is the most affected region in patients with positive cardiophrenic lymph nodes. Patients with radiologically positive cardiophrenic lymph nodes have a decreased progression-free survival and overall survival compared to one without radiological cardiophrenic lymph node adenopathy. The therapeutic effect of removing metastatic cardiophrenic lymph nodes at a time of cytoreduction in patients with advanced ovarian cancer remains unclear. Suspicious cardiophrenic lymph nodes should not represent a contraindication to possible complete abdominal cytoreduction, as the latter remains the most favorable prognostic factor. And the last one are the inguinal lymph nodes. Metastases to the inguinal lymph nodes from ovarian cancer are rare. The inguinofemoral zone is often neglected during preoperative clinical and radiological examination. The incidence of metastasis is approximately 3 to 5% among patients with advanced epithelial ovarian cancer. Here you could see metastasis to the inguinal lymph nodes on CT. The exact mechanism of ovarian cancer metastasis to the inguinal lymph nodes remains unclear. Lymphatic spread through the round ligament or hematogenous spread are thought to be the two main routes. However, and very interestingly, Giri et al. Confirmed that peritoneal spread could also play a role in metastasis to the inguinal lymph nodes. Authors documented peritoneal spread to the inguinal ligaments along the inguinal hernia tract into patients with advanced epithelial ovarian cancer. Palpation and imaging of the inguinofemoral region should be part of diagnostic evaluation of every gynecological patient. Some data questioned the classification of inguinal lymph node metastasis as figure stage 4, as patients with inguinal lymph node metastasis have similar outcomes to patients with paraortic and pelvic lymph node metastasis. Another recent data confirmed that the presence of inguinal lymph node metastasis did not imply worse clinical outcomes compared to patients with all stages 3, 4, and AR0 resection and advanced ovarian cancer patients with inguinal lymphadenopathy resulted in improved progression-free survival. Now, I will briefly describe the limitation of some of the perioperative scores predicting optimal cytoreduction and advanced ovarian cancer. Everyone knows the Sugar-Baker score. However, the Sugar-Baker score, it does not describe metastasis to the retroperitoneal lymph nodes, as it was validated for mesothelioma and mucinous rectal adenocarcinoma, although its higher index is often associated with lymph nodes involvement. The other is the Fagotti score, the laparoscopic score in advanced epithelial ovarian cancer. However, during the Fagotti score and during laparoscopic observation, it is hard to observe for the lesser sac, hewers of the spleen, gastrosplenic ligament, and mesenteric root. Moreover, there is no exploration of the retroperitoneal lymph nodes, which is quite different by laparoscopy. Nevertheless, Fagotti et al. Mentioned that the purpose of the score is to avoid an inappropriate lack of exploration instead of unnecessary laparotomies. Furthermore, disease involvement in areas unexplored by laparoscopy in the upper abdomen could be predicted regarding the dissemination of the disease. The Eisenhower score intraoperatively estimates the extent of the ovarian cancer disease in 5 regions in the abdomen: the right and left upper quadrants, pelvis, central abdomen, and retroperitoneum. However, suprarenal, retrocrural, and cardiophrenic lymph nodes are not mentioned in the scoring system. Suprarenal lymph nodes could be included, as it was mentioned that the retroperitoneal lymph nodes are removed below the crura of the diaphragm. The Sudan score is a predictive score based on the 3 clinical and 6 imaging criteria. The Sudan score describe and observe the most of negative anatomical areas. However, the retrocrural lymph nodes are not mentioned. And Aleti et al. Created a score based on surgical complexity during surgery for advanced ovarian cancer. The authors included 12 surgical procedures, which are pointed here. However, Celiac, suprarenal, retrocrural, and cardiopharyngeal lymph nodes dissection was not described or included in the study, although Aleti included the pelvic and paraortic lymph node dissection as a surgical procedure in his core. In the article, we made a table of anatomical areas, and so when evaluation is recommended and when evaluation is not supported by available evidence, and it is not recommended. For example, Domento bursa, if we have transcranial dissemination, evaluation is not recommended in cases of efficiency in whistle for Rana. In conclusion, surgeons should be familiar with the neglected anatomical areas that may contain residual disease in order to perform optimal site reduction whenever possible. These areas are commonly involved and should be rigorously evaluated in every patient with advanced ovarian cancer, as they often preclude optimal site reduction. Conversely, leaving the negated anatomical sites unexplored leads to compromised treatment outcomes. Scoring system exploring the majority of negated areas that may harbor residual disease and predicting precisely optimal site reduction in advanced ovarian cancer has been not validated yet. Thank you for your attention.